Good evening, everyone.
Good evening.
Dr. Palanivel, Senior Consultant Ophthalmologist, Dr. Agarwal's Eye Hospital, Dr. Agarwal's Retina Foundation, Alberta. Almost I'm with Dr. Agarwal's Eye Hospital for the past 24 years. So today, on behalf of Dr. Agarwal's Clinical Board, the CME Series 35, I welcome you all. And I would like to introduce Dr. Saraswathy. She's been here with us also for more than a decade with us. She is heading the Dr. Agarwal's Eye Hospital Retinal's branch now, and as well as a Retina team. And we're just going to have a discussion about role of retinal lasers in the era of anti-VEGF now. Yes, Dr. Saraswati.
Thank you, Dr. Panelist. Thanks for the kind words and nice introduction. And good evening, all, first of all. Today, I'm here to answer the question, which most of us would have faced at some time or the other. Is there a role of retinal lasers in the era of intravitreal injections? I'm just trying to answer this question in with certain of the inputs. And it's more like, I would like it to be more like a discussion so that it's a question that has propped up in my mind, which I'm trying to answer here. So we all know the retinal lasers were once the gold standard for the treatment of retinal disease. From the time it was first reported by Dr. Judd Mayer Shekhawat for the retinal photocoagulation in the year 1949. Then they built, along with Dr. H. Littman, they built the first xenon arc photocoagulation. From there, lasers have come a long way, from ruby lasers to argon blue lasers to krypton lasers. And with the invent of indirect laser ophthalmoscopy in 1981, the scope of lasers in ophthalmology has tremendously increased. From there was the invention of tunable organic dye lasers, and then the diode lasers, and then the micropulse lasers, to the current lasers which we have in solid state, gas ion state, liquid lasers, and semiconductors also. With the traditional PRP, we also have the Pascal PRP, subthreshold, and the Navilis, and the targeted retinal photocoagulation. Next, please. Even now, the lasers remain a mainstay of treatment in proliferative diabetic retinopathy, diabetic macular edema, retinal tears and detachment, retinal vein occlusions, ROP, extrafoveal polyps of PCV, CSR yields, vascular tumors, and Coats disease and other vasculitis, where ischemia is the main component rather than inflammation, and also radiation retinopathy. But the main bulk of retinal cases where we resort to lasers or intravitreal injections is because of diabetes. We all know globally there is a rapid increase in the diabetic population, and efficient management of diabetic retinopathy, especially diabetic macular edema, is a challenging and a very rewarding treatment, because the management of diabetic retinopathy and diabetic macular edema especially is very, very important to maintain the visual acuity. As we know, diabetic macular edema is the most common cause of vision loss in diabetic patients, and it affects the working population. So we can understand the burden of the problem, and it affects the individual's vision loss, the quality of life, and it is also a huge economic burden both on the individual and on the society. So no wonder we have a lot of RCTs and evidence-based guidelines when it comes to the management of diabetic macular edema. When it is not center involving with a good visual function, still lasers can be the gold standard in DME management. When there is center involvement, because of the availability of excellent molecules in terms of intravitreal injections, they play a huge role when it is center involving diabetic macular edema. Having said that, whenever there is a resistance to any of these treatments as a monotherapy, then a combination is an ideal thing to achieve long-term and better visual acuity. And when there is a tractional component, when it is an advanced retinopathy, then surgery is the last resort. So in diabetic macular edema, as we've discussed earlier, focal and grid lasers were the gold standard. Now anti-VEGF score over in terms of maintaining the central vision. Lasers form an adjuvant for the chronic and the non-center involving macular edema. Especially the micropulse lasers have minimized the retinal damage and improved the outcome in these patients. Next, please. So this is a normal retina. So this is a normal retina. This is the OCT picture. So we can see with the use of intravitreal injection, there's a dramatic improvement in the center involving macular edema before and after the injections. These are the couple of cases. But the challenging ones are these resistant DMEs, wherein in spite of after 1 month, this is the normal OCT. And here we can see macular edema before and after the intravitreal injection. We can see a dramatic improvement in terms of the edema. This is again another case of macular edema which has been successfully treated with the intravitreal injections. These are the challenges when it comes to resistant diabetic macular edema. So this is a patient of persistent macular edema even after intravitreal injections. So in the treatment of this resistant cases of DME is where the clinical experience and the preferred practice patterns of the clinician comes into play. So here the clinician have to have a holistic idea about the patient, the general condition of the patient, the kind of medications they are giving to treat the diabetes, because certain anti-diabetic medications can cause a worsening or a persistence of diabetic macular edema, and also the comorbid conditions like hypertension and CV accidents. All this will go a long way in treating the diabetic macular edema efficiently. It's not like one hat fits all. So that is where the experience and of the clinician comes, and the continuity of the treatment comes. So it's very, very challenging, at the same time very rewarding. So a patient clinician can decide which patient will benefit only with lasers, only with intravitreal injections, or the combination of both. So these are the various modalities with which we can deliver the laser, either slit lamp or indirect, and during surgeries we can use the endo laser. So these are the various types of lasers. And the second main clinical condition where lasers have a strong role is in retinal vein occlusions. That is again the major chunk of the retinal patients suffer because of increase in the hypertension and hyperlipidemia. Earlier, we were only having sectoral laser for the ischemic RV. Now, with the use of intravitreal injections, we can control macular edema and neovascularization. But to prevent the neovascular glaucoma, it is very, very important and to pack them with the lasers, and that's where lasers have a very, very strong role. And they also are useful when the frequent injections are not feasible. Retinal tears and detachments are one place where lasers are still the gold standard. It has the IVI has not changed their role. They seal the retinal breaks and prevent detachment progression. So all the peripheral retinal lesions and all tears and everything can only be efficiently managed with lasers. Next, please. So then we have a lot of laser modalities which are very newer, including micropulse laser, which is subthreshold and tissue sparing. And the same, we also have, instead of the single spot PRP, we have the pattern scan laser, which is faster and a multi-spot delivery. And there are the selective retinal therapy. So in selective retinal therapy, the laser spot is selectively delivered to the RPE cells, wherein there is a microbubble which acts locally and confine the inflammation, avoiding the collateral damage to the sensory retina. And this uses the reflectometric dosimetry, which measures the amount of laser that is delivered so that the collateral damage is reduced. And we also have the naviless or the navigated laser. These lasers use the live image feeds from the OCT. And based on that, the treating physician can overlap these images on the retina and then efficiently treat them very effectively. And then we have the endpoint management, which is it's based on the Arrhenius damage model. They can be used along with our green lasers with the Pascal modality also. Here, basically, a threshold burn is given, and from there, 30% of the energy is fixed so that both the duration and the energy are titrated so that it is efficiently delivered only to the intended RPE cells, avoiding the collateral damage completely. And we also have the subthreshold nanosecond lasers, which are still in the experimental stage with the minimal damage. So with this availability of newer laser modalities, the results are much better and the complications of lasers are also reduced greatly. On another side, we see the rise of intravitreal injections. So they have a major role in the treatment of AMD, both wet and dry is picking up, and center involving diabetic macular edema, edema due to retinal vein occlusions, and CMA is secondary to uveitis or even cataract surgery, non-infectious uveitis, endophthalmitis, CNVMs, and other neovascular glaucoma regression, either standalone or in combination with lasers. So, when is laser as a first line? In PDS, yes, as PRP, and CSMA in focal or grid laser, in retinal tears, ischemic vein occlusion, radiation. So whenever there is a major ischemic component, especially in the periphery in terms of vasculitis or vascular disease, the inflammation component comes, lasers do have a major role. And in spite of extensive laser, if there is a persistence or a recurrence of lasers, then we can reduce the load of anti-VEGF using intravitreal injections. So there's a quick comparison of the lasers with intravitreal injections. A quick comparison of lasers in comparison to intravitreal injections. Sorry for the lag. So we have in laser photocoagulation, the mechanism is there is tissue damage. It destroys or modifies the retinal tissue to reduce the ischemia and then reduce the neovascular stimulus, thereby sealing the leaks. Whereas in intravitreal, it blocks the VEGF, so it reduces the VEGF load. And the various conditions treated are proliferative diabetic retinopathy, retinal tears, lattice degenerations, and ischemic occlusions. Whereas with anti-VEGF, so diabetic macular edema, AMD, and macular edema due to vein occlusions and neovascular diseases. Efficacy-wise, lasers provide a long-term durable control, whereas intravitreals give a quick regression. So when patients have to go for vitrectomy, we can give intravitreal injections earlier, 3 to 5 days earlier, so that they reduce the load quickly, and then so that we can have a better control in terms of surgical thing. And when it comes to complications, in lasers, we have a reduced peripheral field, night vision reduction, and a bit of scarring. When it comes to injections, it's more of infections and inflammation with a persistent increase in the IOP. We have complications of lasers. They can be short-term with the blurred vision, irritation, eye infection, floaters, and sensitivity to light and disturbance in the accommodation. A long-term loss of peripheral field vision because of extensive PRP, decreased night vision and color vision. Sometimes we can have macular damage to accidental foveal hit, and then recurrence of retinal tears when the peripheral retinal lesions are treated with extensive burdens very close to the tear. Sometimes it can open up and there can be a recurrence of retinal tears. Rarely we can have hemorrhage, persistent trace of IOP and RD. We have anti-VEGFs. We have starting from Avastin and Macugen, we have ranibizumab, brolucizumab, aflibercept, faricimab, and a whole range of biosimilars in all these molecules. and they are still newer additions of these molecules for various indications. Next, please. So the complications of intravitreals can be common ones of the transient discomfort at the injection site, foreign body sensation, SEH, mild inflammation and corneal abrasion with a temporary rise in IOP. The serious ones can be cataract formation when there is a injury to the lens, or retinal detachments and tears, vitreous and intraocular hemorrhage, sustained IOP rise, inflammation and endophthalmitis. But they can be injection specific, like in vasculitis in vancomycin and due to DEXA implants. And we can also have problems in patients with cardiac issues and stroke patients with the anti-VEGF drugs. So what are the advantages of lasers today? Because they require less treatment sessions as compared to injections, because most of the indications with the intravitreal injections, either we have to give monthly loading dose followed by PRN, and whereas in lasers there are very few sessions, and they offer a long-term stability, and they are very, very cost effective, especially in settings like in our country, where there is a great disparity in the distribution of retinal surgeons. So you have the rural setup, you have the urban setup, wherein there are limited resources. So in those places, lasers are still major mode of treatment, and they can be complementary to intravitreal injections. So in conclusions, they are going to remain as a vital adjuncts in modern retinal care. They are essential for most of the clinical conditions where the intravitreal injections monotherapy may not be of use. And with the invent of newer lasers, the safety profile is really good. And in the future, we can look for personalized combination of lasers with the anti-VEGFs. Thank you. With this, I personally request Dr. Palanivel, who is almost the authority of lasers, to add his viewpoints and enlighten our audience, please.
Thank you, Dr. Saraswati. You almost elaborated everything. As we come to know, lasers are in the treatment almost more than 5 decades. Still, it plays a vital role in various retinal disorders. So like almost like 2 decades ago, we were doing only lasers. So maybe from 2008-9, we started using an anti-VEGF, and the treatment protocols are completely changed. But I still feel lasers play a good role, as you mentioned. First line of therapy in proliferative diabetic retinopathy and ischemic vein occlusions, and also non-sentinel involving diabetic macular edemas, and also peripheral retinal degenerations. Invariably, you don't have an options, all the peripheral retinal degenerations. And also, I personally prefer in all CSCRs where there is an extrafoveal leaks. So I do go for a primary focal laser, which gives a very good benefits. And apart from that is refractive center involving edema, CSME. So as adjunct therapy or a combination therapy. So when you've gone for too many injections, in between at least one laser supplement, focal laser, or just even a subthreshold laser helps in a better outcome sometimes. So as you mentioned, intravitreals gives good outcomes, but a patient needs a frequent follow-ups and also treatment burdens, cost burden, everything is there. So these are the indications where definitely still lasers plays a very important role. And also, so the laser systems are evolved as we have done from started with diode red lasers, 910 nanometers we used to do in 2000s. But diode red used to give a very good results also, but the scarring used to be very huge. So it penetrates the AZ media, it penetrates cataract, but it's very painful. So we have to give a minimal peribulbar to do the lasers. So it evolved from that. Then we have a 532 nanometers green spectrum NDOG lasers. And now that latest things are, as you mentioned, so to improve that outcomes,
keeping the optimization of effects same and less side effects. So the delivery systems and the type of lasers definitely is still indicates that lasers plays a vital role, like a micropulse diode laser and Pascal system, and also Navy, as you mentioned. So all are it's in fact very good in comparatively it's very good results gives. So apart from these indications, and also as a combination therapy, in cases of retinal choroidal tumors also, hemangioma and other things, after giving an anti-VEGF, we do supplement with lasers therapy also. So lasers are still, I feel it is a vital role in various retinal disorders. Dr. Saraswati, anything you wanted to add apart from these?
Yeah, I mean, I think that vascular lesions, vascular tumors is something which, I would have wanted to mention. There are any more inputs from our doctors or anything else? Any discussions?
There's a question on take on focal lasers. Maybe one of you can answer that.
Dr. Palanivel, would you like to answer
Yeah,
that?
yeah.
Please.
So focal lasers definitely, as I mentioned before, it's a primary indication in non-center involving when the center macula is not involved. So you don't need to go for an anti-VEGF. Yes, I do go for a focal laser in all the non-center involving DMEs. In the question about center involving, definitely we do go with anti-VEGF because of the better outcomes, anatomical outcomes, visual outcomes. We do go with an anti-VEGF. So if it is not benefiting like more than 2, 3 anti-VEGF, the patient has got a recurrence again. So definitely I do prefer doing a focal laser before a next anti-VEGF. So the basically, if you don't arrest the leaking microorganisms or the microvascular leaks, the patients are going to have a recurrent edema again and again. So focal laser in DME, so these are the indication. And focal laser application in CSR, as I mentioned, all the extrafoveal leaks, I do prefer to focal laser first. Only if the leaks are juxtafoveal or a chronic shallow CSCR, then we go for an intravitreal.
There is always a mention of newer lasers whenever we talk about lasers in diabetic retinopathy. How common are we finding the machines and how available are these in general setup? And is there any difference in settings which we use for these? Maybe if we can answer these questions.
Yeah. So availability as pattern lasers is the one which is commonly used everywhere. So pattern laser, it's a Pascal scanning laser system. So it reduces the, I mean, time of the lasers which you're done, and also it reduces the pain compared to the conventional laser because the array of lasers range from 4 to 56 parts, which can be delivered in a very short, quick micropulse intervals. So, which gives the benefit you can complete the pan-retinal photocoagulation in a very quick manner, but it has got few disadvantages also. So, beyond the mid periphery, so focusing and applying the lasers, sometimes it is very difficult with Pascal. Pascal is quite commonly used everywhere. And Navy LAS is a newer thing. It's there, but it's still not widely used. Navy LAS. So conventional, most commonly used is the green 532 nanometer lasers. It's commonly used for both for macula as well as for PRPs and peripheral lasers.
Questions as per protocol S. There is a role of anti-VEGF over PRP. I am not in agreement with that. What is your take on that, doctor?
Yeah, exactly. So if it is a clear-cut proliferative diabetic retinopathy, still I prefer to do one PRP. But if you feel that neovascular component are more, or already if it has started to have an intravitreal gel hemorrhages, so then you can think about an um, combination therapy. Combination therapy. So you can give an anti-VEGF followed by PRP. So that's how it works well.
Yeah, it cannot be like only anti-VEGF
Only
when it comes
anti-VEGF.
to period,
Yes,
isn't it?
exactly.
Okay.
Exactly.
And somebody has asked about sursnate retinopathy. Which one do you do first? Is it the anti-VEGF or the lasers, or how do you treat that?
Yeah. So if it is a sursnate retinopathy, if it is a very small or entire sursnate retinopathy, it depends on it. So it depends on the OCT. If you have an macular edema center involving, preferably to go with anti-VEGF. then followed by that laser. So in the sursonate, if you always see a small sursonate, in the center of the sursonate, you can always see dominant leaking pattern of microaneurysms.
Yes.
So you have
Yes.
to do a confluent lasers in the center of the sursonate or exit while doing the focal laser. Or you can always have an OCT oriented um, findings. So where there is a more thickening in that area, so you can apply the confluent lasers. That will definitely help in the absorption of the sursonate.
So mostly it is a combination therapy that gives
Yes,
the best results, isn't
best results.
it? Right. Dr. Preethi, can we have somebody else has asked? Can we give anti-VEGF in dialysis patients?
It's a controversial question. Yes, you
Yes.
can definitely give. We do tend to get a nephrologist clearance before anti-VEGF. But few nephrologists give good clearance, but few nephrologists prefer not to go for an anti-VEGF. So they say that has some effects on the nephropathy status. So you can assess what was the indication. If the indication is going to be only the edema component, if the patient's renal status is very much compromised, so prefer to go with an Ozurdex steroids rather than the anti-VEGF. But if the indication is going to be edema as well as the neovascular component, you can safely go ahead with nephrologist clearance. Definitely, yes, you can.
But actually speaking, like the anti-VEGF, the only fear is it should not be reducing the systematic thing. But the absorption of intravitreal anti-VEGF into the systemic is very negligible.
Very
What do you
negligible.
think? Yeah.
Yes, very negligible.
So
Very
unless it is, as you rightly mentioned, if it is like a end stage renal and other things, we can definitely use our clinical judgment and explain the patient about the pros and cons, and we can still go ahead if it is important in terms of vision saving.
Yeah.
And somebody has asked, what are the any specific anti-VEGF injections do we give in renal patients?
No, there is no specific either anti-VEGF or you shouldn't think about the Ozurdex.
Yeah, steroids can be used. And what is the time gap between the lasers and the injection in terms of combination therapy?
Yeah, see anywhere time between like 2 to 4 weeks post anti-VEGF. So I do prefer to do in post anti-VEGF like 10 days to 2 weeks, where you have a nice reduction in the thickness. So at the time when you do a focal laser, the efficacy is better.
Correct. See, if the anti-VEGFs are acting over a period of 4 weeks, 2 weeks is the median time when the edema reduction is maximal. So that time we can time the laser treatment to maximize the benefit. So somebody want to know the settings for the focal lasers.
Yeah. So focal laser depends on the machine, but commonly use settings for anything like macular lasers. So you have to use that spot size as minimal as possible. That is like 50 micron spot size. Same as less power as possible. You can start with, depending on your machine's durability, the cable strength, you can start with basic 50 milliseconds power, 50 milliwatts. So you can just then increase the power. But macula always what you need is like more or less like a subthreshold buns, less visible blanching. So 50 milliwatts power and duration and interval also you can just keep as less as possible, anywhere in between 80 to 100 milliseconds.
And I also I think old days practice, I'll try and give a burn with the settings outside the
arcades. Yeah.
arcades.
Then you can pay that.
And then based on that, I'll titrate my burn. I'll try and say just visible. So I think you are in agreement with that.
Yes, exactly.
And in cardiac patients, how long do we wait if you at all you have to give anti-VEGF, or do we even give anti-VEGFs?
No, any cardiological event or neurological event, if it is recent event like within couple of months, so like patient had undergone a CABG or a stenting or a stroke, CVA, so at least for 2 months times, it's better. That's what they also say. It's better to avoid that anti-VEGF. But steroids can be used safely.
During that time, but
During that
after the initial period, I don't think it's a contraindication to use
no,
anti-VEGF.
after 2 months, like 6 to 8 weeks later, it is not a contraindication. First, initial, immediate post event only it's contraindicated. And somebody asked, when is the fill-in PRP indicated?
Yeah.
Yeah. So fill-in PRP, it's depends when we normally go ahead is if the PRP done before or somewhere else, if it is inadequate or skip lesions are there, the patient was a PDR patient, he must have had an vitreous hemorrhage before. So definitely the inferior quadrant, they would not be able to complete it. So one thing is, if it is a PDR with vitreous hemorrhage, incomplete PRP or skip areas, or if still non-regressing new vessels, NVE, so this one indication. Or if the vitreous hemorrhage is recurring again and again, if you have a very frequent recurrence of vitreous hemorrhage, then the fill-in PRP is an indication.
Somebody wants to know, how do we treat subfoveal exudates with the spongiform edema? I think it's almost similar to Saraswathy. You want to add in extra?
So recent studies have shown that with odd exudates, when we go for an injection, was that studies showed that little bit absorption of that exudates in the macula, dense exudates. So subfoveal, there is no way we can clear it. If it is very close, then it's very difficult. But you can always go with an Ozitex, preferably if they have a very dense odd exudates, and followed by focal laser also.
Is there any role of that calcium dobislate, which we used to use?
To give before a lot, because of the lot of systemic
But-
side effects, we are not using it now. But if the patients are not on statin, usually diabetic people, most of them, they will have some of the statins like rosuvastatin or atorvastatin. If they're not on statin, if the lipid profiles are slightly not normal, so that also can be started. Statins also can be started for a short period of time.
One of these newer anti-VEGF injections, they claim they have a better use in terms of subretinal exudates. I think Vabysmo, if I'm right. So, do you think it helps in your experience?
So far, we haven't noticed any big difference, but reduction in edema and regression of the CNVM, longevity wise, slightly better, yes. Otherwise, other conditions that it's same as aflibercept, as equal to aflibercept.
I think we've covered most of it. Thank you so much. Thank you so much for clearing all the doubts and the questions and kindly moderating the sessions. We thank all the participants. And thank you, Dr. Preethi, and I'll also thank Clinical Board for the opportunity. Thanks a lot. Bye.